Our first presenter, and also I don't have notes in front of me, so I'm reading from my mobile, is Penny Fotheringham, from Public Health Advanced, who is a Public Health Advanced trainee from Sydney Local Health District, and will be speaking on qualitative study into the health and social care needs and barriers to service access for Sudanese women living in a socioeconomically disadvantaged area of Sydney. Thanks, Penny.
So I'd just like to acknowledge that I'm presenting on behalf of the other people on the slide there, without whom which this work couldn't happen. So Desmond Raymond is a senior social worker within the Healthy Homes and Neighbourhoods program that I work within, and Sarah Canlari, who's a previous public health registrar in this program. So I work within the Sydney Local Health District. I'm sure some of you have seen this slide before. It's the Sydney Local Health District is the red area in the screen there. There's about 670,000 people that live within our district, and our population density is 5,000 residents per square kilometre. The program that I work within, the Healthy Homes and Neighbourhoods program, was established in 2015. Riverwood and Narwee are two suburbs in the southwest part of the Sydney Local Health District. These were identified with geospatial epidemiology, which was performed as part of the AHHA program development, as hotspots within our district for clients who experience multiple social disadvantages. Both suburbs straddle the border of the Sydney Local Health District and the southeast Sydney Local Health District, as you can see on the map, for their health and social care provision, which can cause some difficulties for the people living in these areas. Originally, Riverwood was an Army naval area, which was then developed into a suburb, so it's a relatively new suburb in Sydney. So the work that we've undertaken in this area was because that the Healthy Homes and Neighbourhoods program, one of our core goals is sector capacity building, engagement and identification of the needs of the communities that we're serving. It has been part of a broader research program which is using community consultation in order to identify barriers and enablers for people who live within our district to access health and social care. Previously to this program, there was a broad community forum which took place in Riverwood, and this has been a continuation of that. So the aim of this part of the program was to engage and identify the health and social care needs of targeted communities. And the definition we have there is because that is the remit with which the AHHA program works, that we look after adult parents, carers and family members who are involved in caring for children aged 0 to 17 years. So what we were proposing to do was to use a qualitative type style study using small group sessions with standardised questions about access to care, according to Penchansky and Thomas from 1981 within those 5 domains. We were aware from the previous broader community consultation that we had missed key culturally and linguistically diverse people within our area to be able to give them our feedback regarding their health and social care. So 2 of the communities that we were concerned about were the Bangladeshi and the Sudanese communities in this area. Following consultation with key community partners and using population level data such as census data and school data, it became obvious that the Sudanese community living in Riverwood should be our primary focus. The second civil war in Sudan from 1983 to 2005 led to a refugee diaspora, and with Australian settlement of mostly South Sudanese people, and the majority between 2003 and 2006. From the ABS census data from 2016, we know that between 2001 and 2010, 10,000 Australian Sudanese people immigrated to Australia, which is 64% of the Australian Sudanese community, and between 2001 and 2010, 6,200 South Sudanese people immigrated to Australia, which is 81% of the Australian population. About 25% of those settled in New South Wales. We know that the language and cultural barriers for this community had prevented them participating in our wider community forum. So how did we engage this community and get them to talk to us? We know that without help from the community itself, this never would have happened. And you can see in the picture there, we've got Deslin and Manal, who is our community consultant who's been involved in this program with us. The relationship with Manal and the community has really been fostered over the past 2 years, and without Manal we would not have been able to do this work. Deslin is embedded within the community as well, and so is known throughout the community centre, the schools and within the Sudanese population, which enables a continuity of care and also just trust for this community. We spent quite a long time, many months, in the area of direct contact with the community to try and get them to participate in our forum, and we were quite flexible in the way that we did this, whether it was through contact, through phoning, emailing, seeing people at home, or through the forum of the local high school. We obviously wanted to ensure that people knew that when they came, it would be both linguistically and physically safe, and that the women would be able to get together and enjoy food. So what did we do? We had an Arabic interpreter present, which was essential. Even though the majority of the women spoke very good English, they tended to switch between English and Arabic. As I said, we based it on the 5 key questions around accessibility, and we were very open and gave opportunity for discussion of whatever people needed to talk to us about. As you can see, we had a facilitator and scribes, and that is Sarah in the picture on the left doing the scribing, one of the other people involved in this program, and then we performed a thematic analysis of the data. So that's just an example of some of the things that we had up on the screen, and the nice food which was actually provided by the women themselves. So what happened in this first part of the program? We had 15 women who attended, and the vast majority were ethnically Sudanese, so not South Sudanese. The average mean age was 40 years, and the mean number of children in each family was 3, and almost all had caring responsibilities for at least 1 child, and it was all women, which is something to note as well when engaging a community and not men. The main things that we found with enablers in accessing the health and social care services, people liked programs which helped them to become part of the community. So things such as job readiness programs at Macquarie College were appreciated because it enabled people to start to become involved in the wider community. They really enjoyed the programs which were held through the Riverwood Community Centre, and from that there was a strong Sudanese community support. So there's a large Sudanese community in that area, and including Manal, who's our cultural consultant, there's many people who are quite prominent in helping people to resettle and to access services and healthcare. And they also appreciated that there were some Arabic-speaking GPs in Lakemba that they felt comfortable with. However, in contrast to this, there was concern that there was inaccessibility of culturally appropriate primary care physicians, particularly for women. There was concerns about the costs of physical therapies after rebate and care plans, and there was some confusion around the way our health system works and what they were used to at home in Sudan and South Sudan. And there was quite a lot of concern about perinatal, childbirth and primary care services, which were unprepared for female genital mutilation or cutting. So I'll just explain that a little bit. So FGM or C is a practice which is entrenched in the culture of many countries, and I've shown Africa there, but it's actually an international practice, and there's quite a prominent number of women affected in Southeast Asia. The WHO estimates that more than 200 million women are affected in more than 30 countries, but given a lot of this is self-reported, it's probably not accurate. The Australian Institute of Health and Welfare estimates that around 53,000 women are affected in Australia. It is a practice that has no health benefits, has multiple serious harms in both the acute and long-term stages, and women who are subject to it normally suffer lifelong physical, psychological problems from it. It is an extreme form of discrimination against women, and it's a violation of human rights and the rights of a child, as generally people who are subject to this are under the age of 15. So we wanted to feed back to the community what they had told us and to be able to explore this further. So apart from some minor technical difficulties, as you can see with our setup for showing a slide in the first picture, the day went well. we discussed the enablers and barriers that had come up as the main themes in the previous session, and we discussed that we wish to have a better understanding for improving their healthcare access, and whether anyone else would be happy to be involved in further discussions, particularly on the themes of women's healthcare and access to women's healthcare services. And of course, we had food. So where do we go from there? Obviously, what we want to do is explore and clarify the key highly sensitive barriers that emerged regarding FGMC, and we're going to be doing this in collaboration and partnership with multiple areas. We are lucky that the women we have met are motivated to improve the healthcare and social care access for themselves and for their community, and that we have a fantastic cultural ambassador in Manal to work with. So at the moment, what we've been doing is involving the services that you can see on the screen there. And after 7.5 months of trying to get an ethics approval through, we're just starting a new project now. So what we aim to do is we want to examine the barriers and enablers for service engagement for women in this area under the umbrella and understanding of FGMC and how that affects their access to services. We know that we need to speak to both the women in the area, but also to speak to the healthcare workers to be able to understand both perspectives with this problem. And if we didn't do that, then it wouldn't be able to inform current practice and also reform local policy and service provision. The other thing that we're addressing within this study is looking at the health literacy of the women that are involved, to understand whether this is a significant barrier to their access to healthcare services, or is it the fact that there is a lack of cultural competence for the healthcare providers that they are seeing. So there you go, that's us. I'm doing well with time.
Thank you, Penelope. And we do have 2 minutes for questions, if there are any questions from the floor. And if there are any questions, could you please just identify yourself before you ask the question?
Thanks, Penelope. I'm Diane from Melbourne. I wonder if you've moved through, has there been any unintended outcomes? Like, I'm thinking, for example, when you brought all the women together to have this woman, has there been a sense of socialisation is with that particular cohort as you've moved through?
Yeah, I think the women that have come, I think because there is a strong Sudanese community, when women have come to the forums, they've really been able to take advantage of that cultural network. And I think there's some people who've come in and maybe known one other person in the group, and they've basically gone away with a network of people that are able to support them. That's one of, and also they've gone away with an overarching understanding of how other people have interacted with health and social care services. So for us, that's quite important as well, that we're sort of facilitating the community aspect of it through doing this work, and facilitating also the trust that they have in the healthcare system and workers, because we're staying in the area and trying to actually look at their needs and utilise that to change the system.
And we have time for one further question. No. Okay, thanks very much.